Good morning, good afternoon, or good evening, or wherever you're joining us from. Welcome to today's GliMR Educational Webinar. This session marks the first of a series dedicated to advanced imaging techniques in glioma assessment, with a particular emphasis on practical implementation and multidisciplinary perspectives, including those of radiographers. So today we will focus on DSC perfusion MRI from concepts to clinical practice. Our program will begin with a concise overview of the fundamentals of DSC, followed by clinical applications in gliomas, and we will conclude with acquisition protocols and practical insights from the radiographer's perspective. We will reserve some time for questions at the end, so please feel free to submit them in the chat throughout the session. And without further ado, it is now my pleasure to introduce the first speaker, Chris van der Weijden. Chris is an assistant professor in MRI physics at the Department of Radiology within the University Medical Center of Groningen in the Netherlands. He specialized in quantitative MRI in the brain, especially diffusion, perfusion, and myelin MRI, and his primary focus is to translate quantitative MRI to routine clinical applications. Today, we will present on the fundamentals of DSC MRI. So please, Chris, thank you very much for joining us. Please share your screen, and we look forward to your presentation.
Thank you, Teresa, for the introduction. Good afternoon, everyone. I'm Kart van der Weijden and work at the UMCG at the Department of Radiology. And I would like to discuss with you some about the fundamentals of the DSC perfusion MRI with focus on clinical applications. First of all, I have nothing to disclose. And the learning objectives of this presentation are first acquiring a basic understanding of the DSC perfusion MRI, identification of key sequence settings that influence DSC acquisition, quality, understand how signal changes due to contrast bolus passage lead to parameter maps, and recognize the differences between relative clinical parameters and quantitative analysis. Healthy tissue vascularization is essential for nutrient transport from blood to tissue, and in MRI, the measurement of the blood delivery to tissue is called perfusion. And one of the main perfusion-related parameters that you actually estimate is the blood volume. So blood volume actually tends to increase when tissue has a higher metabolic demand and decrease upon reduced metabolic demand. Hence, blood volume is often increased in tumor tissue as an increase in cellular density causes an increase of metabolic demand. And blood volume is decreased in neurodegenerative diseases as tissue loss reduces metabolic demand. So perfusion measurements can be performed in multiple manners. In our center within the UMCG, the main method that we use for perfusion assessment in brain tumor patients is a dynamic susceptibility contrast MRI. In DSC MRI, a gadolinium-based contrast agent is injected into the venous bloodstream, and its passage through the brain is tracked over time. As a contrast agent passes through the microvasculature, it creates local magnetic field disturbances around the vessels. These disturbances cause nearby water protons to lose phase coherence, resulting in a drop in signal intensity, as you can see here. Here you see on the x-axis the time and on the y-axis the signal intensity. And to capture this signal change accurately, a high temporal resolution is required. Therefore, a short repetition time, or TR, is preferred so that enough data points are sampled during passage of the contrast bolus. This makes the bolus passage curve more reliable. In addition, Faster sampling also helps to reduce the influence of physiological processes on DSC-MRI, such as pulsatile flow related to the cardiac cycle and breathing. A short TR reduces the sensitivity to these physiological fluctuations and hence enhance robustness of parameter estimation. In practice, a TR shorter than 1000 ms is preferred. To achieve the required high temporal resolution, DSC-MRI is usually acquired with an echo-planar imaging sequence, also known as AP. Typically, several baseline images are acquired at first and often around 5 to 20, and before the contrast injection starts. The contrast agent is then injected at a rate of about 3 to 5 milliliter per second to create a sharp bolus. As gadolinium passes through the tissue vasculature, it accelerates the transverse dephasing, which shortens the T2 and especially T2 star. The effect is generally stronger on T2 star than on T2 because T2 star is sensitive to both T2 decay and T2 prime decay, as you can see here with the typical relaxation formulas. T2 prime is the additional dephasing caused by local magnetic field inhomogeneities. For this reason, gradient echo AP is most commonly used in DSC-MRI, as the gradient echo is highly sensitive to these T2 star changes during the bolus passage. At the same time, DSC-MRI is also sensitive to AP-related susceptibility artifacts, particularly near air tissue interfaces. Therefore, the echo time or TE should be kept as short as practically possible to limit artifacts while still maintaining sufficient T2 star weighting to detect the passage of the contrast. The optimal TE depends on field strength because the AP-related susceptibility effects are stronger at higher field strengths. As a result, somewhat shorter TEs are typically used at 3 Tesla than at 1.5 Tesla, while still maintaining adequate susceptibility contrast. Coming back to the measurement of the bolus passage over time, we can measure the change in signal intensity due to contrast bolus, which is called the time signal intensity curve. For actual parameter derivation from these curves, this time signal intensity curve is corrected for the baseline measurements using this formula. And here you see S0, which are the baseline measurements. And ST is a signal intensity over time, and T is the echo time of the sequence. Using this formula, you will then obtain the delta R2 star relaxation curve. And from this curve, we can extract perfusion-related information. The surface of the peak of the area under the curve, also known as the area under the curve, is called the cerebral blood volume. The time difference between the start and the end of the peak is called the mean transit time, which is the time the contrast takes to travel through the brain. And the relative blood flow is the blood volume divided by the mean transit time. These parameters can give important insights into the state of the vascularization, and this is especially relevant for diseases in which vascularization is altered, like stroke or neuro-oncology. While these parameters generated directly from the time delta R2 star curve are perfectly fine for diagnostic purposes, to determine increases or decreases in perfusion, these parameters might be confounded by aspects related to the contrast injection, bolus delay, dispersion, and cardiac output. Therefore, these parameters generated from the time delta R2 star curve are considered as semi-quantitative and are often referred to as relative blood volume and relative blood flow. To enhance the robustness of the parameter estimations, the tissue curve can be deconvolved to eliminate the aforementioned confounders. However, to enable deconvolution, an arterial input function is required, and an arterial input function reflects the concentration of the contrast agent in an artery over time. An accurate IAF measurement is technically challenging because the arterial input function might be affected by signal saturation, partial volume effects, and vessel selection bias, which is why fully quantitative DSC-MRI is not routinely used in daily clinical practice. To summarize, DSC-MRI tracks contrast bolus passage to assess tissue perfusion. A high temporal resolution is crucial for accurate contrast bolus tracking. Perfusion maps are derived from dynamic signal changes in T2 star during the contrast bolus passage. And clinical DSC-MRI measures are semi-quantitative, whereas quantitative analysis suffer from complexities regarding the AIF generation. First of all, I would like to thank my team and also the organization for the invitation of this webinar. And if you have any questions, feel free to contact me using this email address or ask them at the end of the session. And a lot of the material I discussed today, we also addressed in this publication, which might be of interest if you want to read some of the information back in your own pace. And thank you for your attention.
Thank you very much, Chris, for this clear and essential overview, which provides the foundation for applying this technique then in practice. So as a reminder to all the participants, we will address some questions at the end, so feel free to post them in the chat. And now we move from principles to practice. It is a pleasure for me to introduce my dear colleague Catarina Mendes Pinto, who will discuss the clinical applications of DSC perfusion in gliomas. Catarina has a master's degree in medicine from the ICBAS and a master's degree in medical physics from the Faculty of Sciences and the University of Porto. She is a neuroradiology consultant at Centro Hospitalar do Porto since 2022 and an invited assistant professor of imaging semiotics at ICBAS at the University of Porto. She has supervised neuroradiology residents and mastered thesis in medical and biomedical engineering, and she is the author of multiple publications and presentations at national Portuguese meetings and international meetings. She will present some examples on the clinical applications in glioma. Catarina, I am extremely happy to have you on board and hear your experience. The floor is yours. Thank you.
Thank you very much for the kind introduction. Thank you for the invitation, and good morning, everyone. So I will talk a little bit about the clinical application of perfusion, mainly the DSC. So in this image, you can see a color map of the perfusion. And actually, on our clinical practice, we just use the CBV. So the CBF is also useful, but not in glioma imaging. So I will focus mainly on the CBV. So I have nothing to disclose, and I will center my presentation on clinical cases. And we start with this one, a 45-year-old woman with headache with 1 month progression and intracranial hypertension syndrome. And what you can see on the structural imaging is that she has this lesion, a cortical subcortical lesion in the posterior region of the temporal lobe on the right. And we can see that there is a solid component of this lesion with restricted diffusion, no hematic components, but with enhancement, mainly on the periphery with a necrotic center. So just with these images, we could put the principal hypothesis of glioma, mainly an high-grade glioma because of the contrast enhancement and the restricted diffusion. But we did the perfusion, and actually the perfusion showed that there was an elevation on the CBV, so everything goes in the same direction, and we could conclude that this was a glioblastoma. And after the surgical removal and the pathological specimen, it was confirmed that this was a glioblastoma. So regarding the new classification, it was a IHD wild type. So with this case, I cannot really show you the importance of the perfusion because we could almost take this conclusion just with these sequences of the MR. So where is the real goal of doing a perfusion? What we can obtain behind this diagnose that we could already have with the structural sequences. So I have a few more cases that will show you the role of the perfusion on this case of gliomas that are a little bit more difficult than the previous one. So this is a lady, a 38-year-old lady with new onset seizures. And on these images, we can see that she had a lesion with a hyperintense signal on T2 flare regarding the amygdala, the hippocampus, the subcortical white matter region on the temporal lobe on the left, also in the hypothalamus and optic tract, also on the bulbar area on the left in the pyramid. We could also see a small lesion cortical on frontal on the right and also in the right thalamus. Some of these lesions had restricted diffusion, mainly this white matter area on the temporal lobe, but there was no contrast enhancement. So we had a young lady with several lesions in multiple areas with no contrast enhancement. And the hypothesis was that this was an inflammatory disease. But we did the perfusion anyway, and we saw that on this subcortical area, we had a really high perfusion. We know that the CBV can also be elevated in some very active inflammatory disease, but still this was a little bit too much. So on the report, we say this could be an inflammatory lesion, but we should think about a tumor. And actually, the lady did a biopsy and the histopathology confirmed that this was a glioblastoma. So sometimes the perfusion can really help us to make the difference between some diagnoses that could be milder, like an inflammatory disease, and a really severe disease that need to have post-treatments as soon as possible. So regarding the prognosis, not only the diagnosis, I have this case of a 74-year-old man that has a temporal headache, tinnitus, confusion, and memory loss. And we could see on the MR that he has also a left lesion in the amygdala, hippocampus, and white matter on the temporal and occipital lobe. There was no restricted diffusion and no enhancement at all. So based on these images, we thought this could be a low-grade glial tumor. But we did a perfusion, and we saw that on these areas, actually, there was an elevation on the CBV, so it was an increased perfusion in these areas, and this was really make us thinking that this should be a high grade, regardless the fact that on the MR structural images, we could not find any signal of a high-grade tumor. So this gentleman did a biopsy, and the histopathology showed a glial tumor, none otherwise specified. But on the board meeting, we were very concerned because the perfusion was really high. So we asked our neuropathologist to run some other tests, and they made a genetic panel that shows a third mutation. So on the histopathology, on the macroscopy, there was nothing that would lead us to a high-grade tumor, but he had this mutation that automatically gave the diagnosis of a glioblastoma. Also, the perfusion is very important for treatment assessment. This is a lady with a glioblastoma, and 10 weeks after surgery, she comes back with an increase on T2 flare signal on this area around the surgical resection, with enhancement mainly on periphery, but on perfusion there was no elevation on the CBV. So this was really typical for pseudoprogression. This is radiation necrosis that occurs after the treatment, and it can be confused with tumor progression on the contrast enhancement images, but the perfusion is really, really helpful. Actually, this lady made a new scan 2 weeks after this scan that show that the T2 flare signal was decreased, the enhancement was also decreased, and the perfusion still showed no abnormalities. So we confirmed that this was a pseudo progression. On the other hand, we can also see that sometimes the perfusion is actually helpful to confirm the progression of the disease. And this was a glioblastoma, also operated, and these images are 6 months after surgery, and we could see new nodules on T2 flare with ring enhancement, and there was clearly enhancement on the CBV, so it was a perfusion positive scan. So we thought this could be progression, but still we wait for weeks, 1 month to do a next scan, and on the next scan we can prove that this was progression with more lesions, bigger lesions. The contrast enhancement was progressing, and also we still had the high CBV on perfusion. So we confirmed this was progression. And actually, this case of treatment assessment are the ones where the perfusion really, really help us in differentiating the progression and pseudo progression, since the enhancement can always be misleading. And finally, I would like to say that on clinical practice, we use a lot the color maps, of course. They are really helpful to see where we have the positive spots of high CBV, but we should always look to the curve side of the signal curve. This is the medium sign of a slice, and we can see what we were previously talked about the curve. So we have this drop of the signal intensity, and then the recovery that is not completely, but it is very high in opposing of the regions with the tumor, where you can see the drop of the signal and then a mild recovery. It is really important that we are aware of the different shapes of the curve. So sometimes the curves look like this because it's just a matter of the scale, but still in this case, you can see that there was in the mean slice this really drop off of the curve and almost a total recovery of the sign. And on the tumor, you can see that this recovery is not that big. Also, it's really important to compare the normal side with the side with tumor. Here we have the two ROIs showing this the normal white matter, and we can see that in this case the recovery of the sign is almost total, and here on the tumor the recovery of our sign will be 2/3 of the signal. So this is really important for understanding how the curve perform and how we can interpret the perfusion. And although it's not a glioma, it is really a well-known case where the curve gives you a hint, and I will show you with this case. This is a 60-year-old man with seizures. The seizures were because of these encephaloclastic lesions that was traumatic, but also we performed the MR and we were able to identify this lesion that is really infiltrative on the splenium of corpus callosum with restricted diffusion and contrast enhancement. On the perfusion was negative on the color maps, but when we put the ROI and we try to understand the curve, we could see that this curve not only recover everything of the signal that we had on the baseline, but also we have an overshoot. So the signal intensity recovers more than we had previously, and this is a classical case of overshoot on CNS lymphoma. So we should always have this in mind when interpreting the color maps, because the color are just the area under the curve on these curves, but sometimes it can be misleading when we have these overshoots. So I hope that I bring you the principal applications of DSC perfusion on clinical practice. And I thank you for your attention. And at the end, I'm happy to answer all of your questions. Thank you very much.
Thank you very, very much, Catarina. I think that the examples that you showed illustrate beautifully the challenges that we face in our clinical practice. And this really explains why we actually should include this type of advanced techniques routinely in assessing these patients. Or sometimes even added when there are initially some doubts about the diagnosis and we were not thinking about tumors, but we should keep them in our mind.
For sure.
We will now move to the final presentation, focusing on a crucial but sometimes underrepresented aspect of advanced techniques, the acquisition. And it is my great pleasure to introduce Davide Freitas. Davide is a radiographer in the neuroradiology department at Unidade Local de Saúde de Santo António, also in Porto. He lectures in radiology at the School of Health and the Polytechnical Institute of Porto, and he has postgraduate qualification in advanced radiological techniques. On behalf of the GliMR Taskforce on Education, I would like to thank Davide not only for lecturing today, but also for his active role in actually suggesting this set of webinars and all his effort into helping in the organization and putting these webinars together. I cannot thank you enough. And I look forward to hearing your practical tips. Go ahead, David. Thank you.
Thank you. And good morning, everyone. So my name is Davide Freitas, and I'm an MRI radiographer working in the neuroradiology department at Centro Hospitalar Universitário de Santo António in Porto, Portugal, a center with a strong focus on clinical neuroscience. And I would like to thank the European Society and the GliMR group for this opportunity. I have no conflicts of interest to declare, and this presentation reflects my experience as an MRI operator across multiple vendors and does not represent any specific preference or affiliation for anyone. So, building on the previous talks, we have already covered the fundamentals of DSC and these clinical applications in gliomas. And my focus will be on the practical side, how we actually perform the DSC in clinical setting. And we are dealing with a susceptibility-based perfusion technique driven by a gadolinium bolus. And as you know, the quality of the results depends heavily on how the acquisition is performed. So I will focus on how to perform the DSC perfusion and how to perform it well. I will start with a practical based protocol for DSC acquisition, then explore the technical considerations and parameters that directly impact image quality, and finally focus on recognizing common pitfalls and how to troubleshoot them in clinical practice. Well, DSC MRI acquisition is based on a sequence that maximizes the sensitivity to magnetic susceptibility effects while remaining fast enough to capture dynamic change over time. For that reason, we rely on a T2 star weighted gradient echo API sequence, which is inherently sensitive to T2 star signal decay and allows a rapid whole brain coverage. This combination makes it the standard approach for this type of image. So the backbone of the acquisition is this API sequence. The main advantage of the API is speed, It allows us to acquire whole brain volumes within 1 to 2 seconds, which is essentially to accurately capture the first pass of the contrast bolus. At the same time, it provides a strong sensitivity to susceptibility effects, which is exactly what this acquisition or this analysis relies on. However, this comes at a cost. API is highly sensitive to magnetic field homogeneities, leading to geometric distortion and signal dropout, particularly in some regions, some areas like skull base, temporal bones, or frontal zone. And in addition, signal heterogeneity and spatial warping can affect the reliability of perfusion measurements if it's not recognized. The performance of this sequence is also strongly dependent on the gradient system capabilities, particularly the gradient strength and the slow rate, which have directly impact in the echo train range and the image quality. Alternative approaches such as the T2H spin echo sequence are less sensitive to susceptibility artifacts, and the lack of the sensitivity that they have, they are not so suitable for standard and clinical settings for standard dynamic susceptibility contrast. Here we can see the susceptibility of this sequence here in the temporal lobe, in the distortion of the orbits, especially compared with a fast spin echo flare wedge sequence. And here we can see this distortion caused by the frontal sinus, especially when compared with a same susceptibility wedge image, SWI. Repetition time is a key parameter in this acquisition, as it directly determines the temporal resolution. In practice, we aim for a TR between approximately 1200 and 2000 milliseconds, which results in a temporal resolution of about 1 to 2 seconds per volume. This is a critical balance in the clinical setting. This acquisition must be fast enough to accurately sample the first pass of the contrast bolus, but not so fast that we excessively increase T1-related effects or compromise the signal stability. If the TR is too long, we can lost the temporal sampling, we risk the bolus, and we risk losing important hemodynamic information. A maximum TR of 2000 milliseconds provides a good balance between anatomical coverage and temporal resolution. This is maybe the trigger, the higher trigger of the TR we can use. And of course, we want a shorter than this. So TR is not just a timing parameter, it defines how well we capture the physiology we are trying to measure. Echo time is a critical parameter as it directly determines sensitivity to susceptibility effects. In practice, TI must be long enough to capture T2 starred signal decay induced by the contrast bolus, but not so long that signal to noise ratio is excessively reduced. This is why TE is typically adapted to the magnetic field strength. At higher field strength, such as 3 Tesla, we can use shorter echo times because the susceptibility effects are stronger, and so we have this capability. Flip angle plays a key role as it determines the balance between T2 susceptibility effects and T1 related signal contributions. Lower flip angles favor a more T2 star dominant signal, as the flip angles increases, T1 effects becomes more strong and more prominent, especially in the presence of contrast leakage, what is critical in tumors and gliomas. In practice, intermediate values provide a balance, but understanding these interactions is essential to accurate DSC imaging. The number of dynamics is essential to ensure proper temporal coverage of the contrast bolus. Typically, we aim for around 60 to 100 dynamics, which allow us to capture the full sequence of events from the baseline, bolus arrival, first pass, and recovery. If the number of dynamics is too low, we risk missing critical phases of the bolus passage, leading to inaccurate estimation of perfusion parameters. On the other hand, acquiring too many dynamics may lead to an unnecessary prolonged acquisition, increasing time, increasing motion. So the goal is to have here a sufficient temporal sampling while maintaining the acquisition efficiency. Contrast administration is a critical component as the entire technique depends on the accurate detection of the first pass bolus. Typically, we use a gadolinium-based contrast agent dose between 0.05 and 0.1 millimole per kilogram. The injection rate is equally important, usually between 3 and 5 millimeters per second, and focus here in the higher values. To ensure a compact and well-defined bolus, a saline flush around 20 milliliters is then used to push the contrast through the circulation and maintain the bolus integrity, and is very, very important. If the bolus is too slow or dispersed, the signal drop becomes less pronounced and less accuracy of the measurements is compromised. Behind the acquisition parameters, several technical factors directly impact the precision. Bolus quality, leakage effects, and preload strategies all can significantly influence the signal and the final perfusion maps. So, bolus quality is a fundamental determinant of the DSC reliability. Ideally, we aim for a compact and well-defined bolus, which will result in a sharp and deep signal drop during the first pass. This allows us to accurate characterization of the hemodynamic response and improves the quality of the arterial input function. If the bolus is dispersed, the signal becomes more broader and less pronounced. And this reduces the contrast to noise and can lead to underestimation of perfusion parameters. So in practice, bolus quality is not just a technical detail, it directly impacts the accuracy of dynamic susceptibility contrast measurements. And some dummy scans can be addicted. They are initial radio frequency excitation acquired before the actual data collection, which are not stored or used for analysis, but bring the magnetization in a steady state equilibrium in favor of a better baseline and a better curve. Here with an example, a good contrast bolus as a clear and characteristic shape. It starts with a stable baseline before the contrast arrival. Then we see a rapid arrival with a step drop in signal. The signal reaches a well-defined minimum during the first pass, and the peak should be narrow, reflecting a compact bolus. And finally, there is a smooth and progressive signal recovery without excessive distortion or overshoots. One of the main challenges is leakage of contrast agent outside the vascular space, the leakage effect. In tumors, particularly high-grade gliomas, disruption of the blood-brain barrier allows gadolinium to extravasate into the interstitial space, and this introduces T1 effects that counteract the expected to start signal drop, often leading to the signal recovery above the baseline, the so-called overshoot, that can take some problems to the interpretation of the curves. So we must take some actions to reduce this problem, as one of these is the preload correction. To mitigate this leakage effect, two main strategies are commonly used. One is the preload administration, and the other is mathematical leakage correction. Preload refers to administration of a small dose of gadolinium-based contrast agent prior to dynamic acquisition, typically 5 minutes before the main bolus. This partially saturates the T1 effects in tissues and reduces the impact of the contrast sterilization during the dynamic acquisition. In addition, post-processing leakage correction algorithms can be applied to compensate residual T1 and T2 star effects. These approaches are often used together in high-grade tumors. The flip angle is also an important parameter to adjust with this strategy. When no preload is used, the flip angle should be kept low, typically around 30 degrees. Even with an optimized protocol, several technical challenge can significantly affect the quality of the acquisition. In this section, we will focus on three common issues: motion, susceptibility artifacts, and incorrect AEF selection. These factors can distort the signal time curve and lead to unreliable perfusion maps. So one of these motion is one of most common and impact source of error because this acquisition relies on a subtle signal changes over time. Even small patient movements can introduce abrupt signal fluctuations that distorts the signal time curve. This results in spikes. In some spikes, we can see in the baseline or in the contrast in the bolus passage. In severe case, motion can render the acquisition non-diagnostic. Although post-processing motion correction can help in some way, but fully recover lost signal consistency. Susceptibility artifacts are inherently to this technique. However, some regions with strong magnetic field inhomogeneities, such as near the air-bone interfaces, or when we have some blood in the lesions, can cause this geometric distortion, signal dropout, and spatial misregistration. The arterial input function is a critical component, particularly for quantitative analysis. It represents the contrast concentration over time within an arterial vessel and serves as a reference for perfusion calculations. However, incorrect AEF selection is a common source of error. If the chosen vessel is affected by partial volume effects, delay, dispersion, or noise, the result curve will be inaccurate, leading to errors in the perfusion metrics. AEF selection typical localization is in the middle cerebral artery because of the high signal to noise ratio, the early arrival of contrast, and we must look for the best curve, representative curve. Even with an optimized protocol, issues can still occur during the acquisition. A weak bolus is reflected by the less pronounced curve with a limited signal drop. It can have multiple causes, but careful monitoring of the injector parameters, as we can see here, particularly the pressure profile of the automatic contrast injector, can help to predict the quality of the bolus. This should be smooth and with lower pressure values. Avoiding kinks in the catheter level is important precaution to maintain the fluidity of the injection. And this can happen when the patient bends their elbow, leading to blockage of the flow within the catheter that makes here a kink. For glioma indications, always use a preload strategy due to the potential breakdown of the blood-brain barrier. It is typically performed before the T2 sequence in order to save time within the protocol and use the same injection rate at the main bolus, essentially as a test run to ensure optimal bolus delivery. On motion is preferably to repeat the scan rather than lose the acquisition, particularly when we assessing pseudo-progression versus true progression. For small motion, such as that show in the left video, the current processing tools available in the clinical setting allow for a minor correction. Inaccurate perfusion maps should prompt careful review of the AEF selection and ROI placement. For example, this curve shows some irregularities and small signal drop, only about 22%, with ROI repositioning and selection of a higher quality AEF, like we see here and here, we can have a better curve. And here we have a signal drop around 85%. Just to highlight the key parameters of the acquisition, we often focus on individual settings like TE or TR, but all plays an important role in the acquisition. This is why having a checklist is so important. So before starting the acquisition, there are a few key things to check. First, make sure you have a good IV access, ideally an antecubital vein, 20G or larger with no kinks. A 20G catheter presents the optimal balance for MRI contrast ejection and allows high flow rates. Then ensure the patient is stable and comfortable, as even small motion can affect the results. It's also important to have contrast and saline ready within the injector properly set up. And finally, optimize your protocol timing, including the preload, to ensure everything runs smoothly. During the acquisition, the focus shifts to monitoring and consistency. Make sure you are following the key parameters again. It always a balance between spatial coverage and temporal resolution, what anatomy you want to show. Check the baseline if is stable before the contrast arrival. We can check the first image, looking for the presence of some artifacts. And finally, monitor the injection, especially the pressure curve, to ensure a good quality bolus. After the acquisition, the focus is on validation. Start by assessing motion and overall signal quality. Confirm the signal drop occurring, reviewing the sign image. Evaluate the AEF curve to ensure it is reliable, and storing this file to proof of quality. Generate the maps, the algorithm based or the AEF based or both. And if the result seems unreliable, don't hesitate and do another ROI or calculate again the AEF. I have here some 2-3 cases of some situations. Let's start with this one. Sorry. Here we have an acquisition where there is no significant signals change. The resulting cerebral blood volume map shows very poor differentiation. This is a typical scenario where the contrast bolus never reached the circulation, in this case due to the loss of the IV access, like sterilization of contrast. The white line here represents the IF, so with the absence of bolus arrival. Here, in this case, we can see a delayed contrast injection. The curve shows a late arrival of the bolus with the signal drop occurring much later than expected. This usually reflects a delay in the construct administration or timing mismatch between the injection and the acquisition and could compromise the reliability of perfusion analysis. And in this case, we have a signal decay curve that represents, that demonstrates a less pronounced curve, more rounded peak, resulting from a bolus of 2 milliliters per second. And here is the balance of what we looking for, a most narrow peak. From a more aesthetic standpoint, we should always adjust the thresholding, removing unwanted signals here and here to create a cleaner image. However, this should be done without exaggeration because we can, without removing anatomy, like here in this anterior component, we must preserve all the anatomy and not be exaggerated. So, DSC is a valuable tool in neuro-oncology, but its reliability depends on proper acquisition, careful monitoring, and validation. This clearly highlights the role of the radiographer in ensure high-quality data. DSC also offers important possibilities for quantification with different modeling approaches and advanced tools behind the typical clinical environment can help to extract even more information from this technique, and these aspects could be explored further on not another occasion. And thank you.
Thank you very much, David, for this overview of all the steps that are necessary to take into consideration for acquisition, and also the importance of the post-processing in order to obtain reliable information to use in clinical interpretation. We are running a little bit out of time, but we have some questions in the chat. The first one is from Albert Ponzescoda. He is asking, regarding essential technical considerations, wouldn't you also consider that in addition to TR and TE and the use or not of an AIF, parameters such as flip angle, pre-bolus use, and the leakage correction approach are important and with high potential impact on the robustness of CBV estimates? I think that you, David, covered some of these issues already, the importance or the guidelines that are now on the flip angle and the pre-bolus or importance. Would you like to stress a little bit again some of your tips on this regard?
In our practice, we have a strategy that use the preload, the pre-bolus, because our main application of this technique is for gliomas, and we trying to maintain the strategy the same that we could compare between cases, and we have a stability strategy for all the cases. We at the same time we use the both strategies. We can use the preload, and after that we can make the leakage correction mathematically approaches, and we do that often. We use algorithms to process the acquisition, and we use the AF to estimate the perfusion too and to show the correct acquisition, and we use always the preload doses by now.
And this also goes in answering another question that asked exactly that. Would you agree that irrespective of pre-bolus administration, post-processing leakage correction remains necessary, mostly commonly using the Boxerman-Schmeide-Weisskopf method as recommended by current consensus guidelines? In other words, I would say these strategies are complementary rather than mutually exclusive. In summary, post-processing leakage correction should always be performed regardless of pre-bolus or not. This is another comment from Albert Pons Escoda. In my clinical practice, I also do both the pre-bolus and the leakage correction. Any other comments from any of you? And I think I will have a final question that is regarding clinical applications. Do you consider DSC perfusion to be reliable for detection of pseudoprogression? Tumor recurrence or progression within the radiation field can sometimes present with low RCBV, while cases labeled that pseudoprogression may also show elevated RCBV. In my experience, follow-up beyond the 12-week post-chemoradiotherapy window remains necessary to confidently differentiate between pseudoprogression and true progression. With perfusion often add an limited incremental value. There are also several studies reporting negative or inconclusive results for DSC PWI. Any comments on this? Maybe Catarina?
Yes, it's always a pleasure to have this kind of discussions with Albert. That is really a person that I really enjoy hearing about this team. So yes, of course, I show some examples that were a little bit straightforward for the illustration of the technique. But yes, this is our clinical practice. We are never sure. And of course, that's why we also prefer the time to tell us the truth more than the perfusion. And that's why when we have doubts, we repeat the scan 1 month after we are in the doubt between progression or pseudoprogression. Furthermore, in our clinical practice, we try to also do the measurements of the CBV. So we have our own cutoffs and we work a little bit with that to be a little bit more sure about progression and pseudoprogression. But of course, pseudoprogression can have elevated CBV, but when the cutoff is really higher than what we expect, we can be a little bit more confident that it is progression. But yes, I agree with Albert that we still focus on the progression over the time more than just on perfusion to conclude, and mainly when there is big implications for treatment for the patients. And I will also use this question to answer the other one regarding the glioblastomas, that one has really high perfusion value and the other one the perfusion appears lower. And the question is if this is explained by difference on clinical or biological behavior of the tumor. I would say both biological the biology of the tumors may be different, and also the time where we are looking at a tumor. So if we look to a glioblastoma early on the development of the tumor, probably it will have maybe some kind of cellular turnover that is not enough to have neoangiogenesis. So maybe we don't have the CBV already elevated, but we have the contrast enhancement, but it can be the other way around. So sometimes there is no neoangiogenesis enough to see it already. So I would say that both the clinical and biological performance are different in these tumors.
Thank you, Catarina. I agree that we should include these techniques, but don't look at them blindly. And actually, that shows us the room for improvement on the use of these techniques. And I agree that having some kind of quantification and looking at trends rather than one specific time point is important, and also the clinical condition of the patient always into account. I think we are running out of time, but I thank you all for joining us and for your participation, and I hope that you found this session useful for your practice, and we look forward to welcome you on future GliMR educational webinars. Have a great day. Bye-bye.